First, I just wanted to say, so I was just pinch hitting for Dr. Ryan, but I'm Brandi Reeves from the University of North Carolina in Chapel Hill, and I'm here representing my team who couldn't all travel with me. So as I was just mentioning, it takes a team to manage MPN. And so back in Chapel Hill right now are my colleague, Dr. Hank Van Deventer, my nurse practitioner, Becky Salchuk, our nurse navigator, our clinical pharmacist, right? We're hiring another MPN doc because there's so many patients. I was fortunate enough to be able to start our MPN clinic in 2019. We've grown to over 600 MPN patients. So again, when you all were saying it's really not that uncommon, it really is not all that uncommon. And Duke is 8 miles away from us, right? So there are plenty of patients out there. And so getting together like this and sharing your stories, I think is hugely impactful. We learn from it, you learn from it, and I hope that we all move forward with that. I'm also a scientist, and so I spend actually the majority of my time in the lab, and my research focus is trying to understand what causes the blood to clot a little too well in these diseases. And then we're venturing out into some other spaces, including kidney disease. And so today I was going to talk about kidney disease and then also about iron, which I think is hugely important and has come up over and over again here. So without any slides, here's what I'm going to do. I'm going to wing it, you guys, okay? So iron deficiency is highly prevalent in MPN, especially polycythemia vera and essential thrombocythemia. So it's somewhere between 80 and 95% of ET and PV patients are iron deficient on their bone marrow biopsies at the time of their diagnosis, and that's before any treatment. By blood checks, it's about 50% because the blood is not as sensitive as the bone marrow for looking at iron stores. So iron deficiency is a big problem. And so to understand iron deficiency, I think you have to understand what is iron and how does our body handle iron. So iron is a metal, right? And it's actually integral in many of our processes in our body. So it's important for your hemoglobin to carry around oxygen and deliver oxygen to tissues. It's important for muscle, so skeletal muscle, cardiac muscle. It's really important in everything we do. And because of that, iron regulation in your body is very tight. So what comes in stays in, and so there's a net even balance every single day. So you have about 3 grams total of iron in your body, so 3,000 milligrams. So 2/3 of that is actually in red blood cells. So the red blood cells are red because they're full of iron, right? And so 2/3 is in your red blood cells, 1/3 is in your liver, so in a storage form in your liver. You take in about 1 to 2 milligrams of iron a day. So again, 3,000 milligrams total. You're taking in about 1 to 2 milligrams, and you're getting rid of about 1 to 2 milligrams. So the only way we have to get rid of iron is actually like sloughing it from our skin cells, and a little bit of it comes through our feces. So what comes in stays in, but there's not a whole lot coming in, so net even. You can imagine as a woman that we are more prone to iron deficiency because 2/3 of the iron is in your red blood cells. So every month when you have a menstrual cycle, you're losing iron. And in 1 bag of blood, which is 500 milliliters, there are roughly 220 milligrams of iron. So you think about that in terms of what you're taking in and what you're losing, right? So you can quickly become iron deficient. So in terms of polycythemia vera, when we have therapeutic phlebotomy, with each therapeutic phlebotomy, you're losing 200 milligrams of iron. So pretty quickly, you become iron deficient, and iron deficiency is then universal in polycythemia vera. And because iron is so important for all of the processes in our body, you can be very symptomatic with iron deficiency, even with normal blood cell counts, right? And so you can be tired, you can have restless legs at night, you can have shortness of breath, you can actually gain weight because of iron deficiency, like what none of us want to do, right? And so you can lose your hair. You can actually have mouth sores. And so iron deficiency isn't fun. So even though we talk about therapeutic phlebotomy as being relatively cheap, although Dr. Ritchie earlier today was talking about, is it really that cheap when you have to take a whole day off of work and it's a 10-minute procedure, but you're sitting in the office for 4 hours? Probably not. But it's not super well tolerated always by patients. So in fact, there was a landmark study, the 2.0 study just published earlier this year, suggesting that 25% of PVERA patients felt worse after starting therapeutic phlebotomy. So they were distressed by the therapeutic phlebotomies. Not only are there symptoms, but there's suggestion that iron deficiency actually increases the risk of blood clots. So, and this is in non-MPN patients. If you take folks who are iron deficient versus folks who aren't, and you look at the blood clots, there's 6 to 10-fold increased risk in those with iron deficiency as compared to those without iron deficiency. And that's both for venous and arterial events. Now, what's not clear is if it's what's causing the iron deficiency, or is it the iron deficiency itself? Dr. Joe Percol and G. Song at the University of Utah think it's not what's driving the iron deficiency, it's the iron deficiency itself. It turns out that many of the genes in our body actually utilize iron for their signaling. So when you lack iron, those genes then behave a different way. So you might turn on a different set of things that you didn't have before. So the things that we are very interested in are the blood clotting factors. And it turns out that when you're iron deficient, your blood clotting factors actually increase. And they're the ones that make your blood sticky, not the ones that are causing normal, healthy blood clotting. And so Dr. Percol was actually very clever when he did this because he's been anti-phlebotomy for a long time. I don't know if you all have heard him talk. He really dislikes phlebotomy. It's not fixing the disease, right? And it's just making everybody iron deficient. And so he actually set about a very practical study of looking before and after correction of iron deficiency in patients with ET and PV. What happens to these blood clotting factors? And it turns out that after you replace iron in the same person, the blood clotting factors normalize after replacement of iron. So iron deficiency probably isn't doing you any favors other than controlling your hematocrit, but what is it doing long term is not clear. Now, I recognize that you're not big mice. However, we know from Dr. Radek-Skoda's mouse model of polycythemia vera that if you make a mouse iron deficient that has polycythemia vera, you actually get more myelofibrosis that develops in the bone marrow. And you can look at that in mice because they have a pretty short lifespan, right? It's hard to do that in humans. There was a retrospective study from Cornell, which has problems because you're looking back, not forward. But in that retrospective study of over 500 polycythemia vera patients, the patients that were treated with phlebotomy alone as compared to hydroxyurea or interferon, phlebotomy alone had the worst myelofibrosis-free survival curves. So they were the most likely to develop myelofibrosis over time. And that's curious, isn't it? So is it just that it's lack of disease modification and this is what was going to happen? Or is it doing something maybe to speed up the process? The mice would suggest it's doing something to speed up the process, but we're not sure. Nevertheless, iron deficiency is probably not great for you, right? So then if iron deficiency is so bad, but it's controlling our hematocrit, what do we do about it, right? So, and that's where we have to weigh the risk and benefit. So we go, okay, so we know it might make you feel better. Maybe that wasn't all of your symptoms, but we know also that replacing it might drive your hematocrit up, and if your hematocrit's too high, then you're at increased risk for clotting. So we have to just be very judicious about what we're doing, right? So I do not encourage any of you to go off and just start iron supplementation on your own. I highly recommend that you work with your MPN doc on this because it's very individualized. So first, if I'm going to replace iron for a patient, I need to make sure that that patient has excellent cell count control before I replace the iron. Otherwise, I'm just going to make everything worse. And if you're being treated with therapeutic phlebotomy, where I'm removing iron and then I give it right back, guess what? You're going to need therapeutic phlebotomy more frequently, and I haven't done anything at all to help you. So I'm going to make sure that the cell counts are well controlled, usually with some sort of cytoreductive therapy. And then I'm going to decide how much iron I need to give. Can I just give it by pill? So like a Flintstones vitamin or a one-a-day vitamin has 18 milligrams of elemental iron. And you absorb about 10% of that. So that's going to be roughly 2 milligrams of iron that you get over and above what's in your diet. Or do I need to be a little more quick? Are you super symptomatic? Are you anemic? And do I need something like ferrous sulfate, which has 65 milligrams of elemental iron? Or do I need to bypass those entirely? Does iron upset your stomach and cause issues? Do I need to go to the vein? And if I'm going to the vein, how much am I going to replace? Probably just a little bit at a time, right? And I'm going to keep an eye on that and check probably every 12 weeks to see how you're responding. Then kind of the cool thing is in polycythemia vera, I think one of the major questions has always been, why is the majority of patients, why are they iron deficient even before we've done anything to them? And it turns out that there's a really brilliant answer here, and that is the red blood cell, or the parent of the red blood cell that has the JAK2 mutation, actually makes a hormone called erythropoietin that signals to your body to give iron to it. So it needs that iron to make more red blood cells, right? And so when it does that, it causes what's called a hepcidin deficiency. So you guys have heard about hepcidin recently. So when it causes the hepcidin deficiency, then you're allowing the storage iron in macrophages to be released to this red blood cell producer. There has been a drug called rusfertide, which is a replacement for that hepcidin, that helps to increase hepcidin and trap iron in those cells so it can't be diverted back to the red blood cell production. And at ASCO this year, you've heard about this a little bit already. Dr. Kirkendall reported on behalf of the phase 3 Verify trial that not only was rusfertide very good at controlling the hematocrit, it also it was normalizing some of the iron parameters as well. It was very good at controlling some symptoms. And that's hugely important, I think. So now you have something that might control not only your hematocrit, but improve some of your iron deficiency symptoms as well, right? And so we're super excited about that class of drugs. What we're not sure of is exactly how they're going to be placed in the treatment of polycythemia vera. I currently see them as add-on therapies to your regular cytoreductive therapy and time limited, but we'll see how that goes. I think if there was additional data suggesting that they had true disease modification, if they could really control this inflammation and target those stem cells, then great, maybe standalones. But for right now, I see them as time-limited add-on therapy. Let's see here. All right, so then I guess we'll talk about chronic kidney disease for a second. Okay, how many of you have heard, well, those of you for here last year, don't raise your hands. How many of you have heard that kidney disease is a major problem in MPN? Excellent, so a few of you. All right, it turns out 80% of patients with MPN have chronic kidney disease, 80%. That's over 5-fold higher than the general population. That's a big deal, right? And so most of that kidney disease is not super severe. So like, we're not all on hemodialysis here. So most of it is mild, but there's about a 7-fold increased risk in the more severe kidney disease, so what we call the stage 3 kidney disease, which is the stage at which your kidneys aren't filtering very well, and we might have to start adjusting our medications and think about, gosh, how do we make sure you're not losing any further kidney function? And so there have been a couple of studies looking at, all right, so we know there's kidney disease. What are the risk factors for kidney disease? And these are all retrospective studies, so they're as good as we have currently. And it turns out that one of the major risk factors is prior history of blood clots, which really got my attention, right, because I study blood clotting. And so is it possible that this is just small blood clots in the kidneys leading to this chronic kidney disease? Might that be an organ that we can look at in terms of having a biomarker of response, for instance, in our clinical studies? We're not sure yet. The other thing that was really interesting is if you had myelofibrosis, you are also more likely to have worse kidney function. And whether that is because myelofibrosis is very inflammatory or whether that was myelofibrosis because you've had PV or ET before and so you've had disease for decades is not really clear from the data that we currently have. There have been a few studies looking at, was there any therapy that impacted the trajectory of kidney disease? And right, these are really tiny studies with really poor data so far. But what they've shown so far is anagrelide did nothing for kidney function. In fact, might have made things worse, which is a curious story because you all have heard that it can also increase bone marrow fibrosis, and it's really fallen out of favor for use here in the United States. Hydroxyurea might have leveled things off and maybe improved kidney function just a bit, but it's not the be-all end-all. Ruxolitinib, there's one paper from Surge for Stavsek suggesting in myelofibrosis that ruxolitinib can improve kidney function, but there's another paper refuting that, suggesting it had no benefit on kidney function whatsoever. Aspirin is plus minus. In myelofibrosis, it looks like outcomes are worse, but in PV and ET, it looked like things were pretty stable on aspirin. But again, these are small numbers, low quality data. In terms of what's going on, so I was fortunate to get funding from the MPN Research Foundation just last year to collaborate with Stefan Koschmieder at the University of Aachen in Germany to do our first prospective study on kidney disease and MPN. And so we are collecting blood and urine samples from patients to see if we can identify factors that predict for the accelerated loss of kidney function, and finally better understand this and see also if that might be some biomarker that we can use when we're looking at drugs. So we've been looking for the holy grail for how do we know if we're going to get a blood clot, right? And we all have heard about cell counts, and last year I told you cell counts don't matter so much. It's really the qualitative changes of the cells that are mediated by these JAK2 and calreticulin mutations. So is that something that we've stumbled upon with the kidney? We're not sure, but we're hoping that with your help, we can answer that. And I think, since I don't have slides, and which is probably great for you because there was a lot of just pictures of kidneys and, like iron handling in there, livers, that we will end. First, I want to say thank you to Anne. This is, I hope it's a great meeting for you. As a clinician, it's a fantastic meeting for me. I love meeting all of you. I love seeing my colleagues here and learning from them. Anne does a wonderful job of gathering everybody up. We're like herding cats. I mean, she had 3 people drop out today. Thank you to our industry partners who help support this. And thank you to all of you for showing up and for staying here and looking me in the eye as the very last presenter of the day.